Thank you so much, and good morning. I want to thank the organizers for the invitation. I've been wanting to get up here for this conference for a while. Couldn't make it happen due to COVID several years ago, but pleasure to be here. And certainly an honor to follow Dr. Cummings, who's been a pioneer in this area. And really today, what I hope to do in this presentation is really take a clinical view of use of incretin-based therapies. I'm going to use the ADA guidelines as a structure and talk through some of the more recent recommendations and data supporting those recommendations, and maybe add some thoughts as to where we might see these recommendations changing, because really we're only about 2 months out from the next iteration of the ADA guidelines, which is a huge undertaking each year to get that ready and incorporate new evidence on a rolling basis. There we go. Here are my disclosures. And in terms of learning objectives for this presentation, I want to review updated recommendations for use of GLP-1s and our dual GIP-GLP-1 receptor agonist in type 2 diabetes, again, using the ADA standards of care as my structure for the presentation. List proposed mechanisms of cardiovascular, kidney, metabolic, and really beyond that, benefit with incretin-based therapies. And then for the last few minutes, I want to discuss some incretin-based therapies in the developmental pipeline. There are many, but I wanted to share some data from some of the more advanced agents in the developmental pipeline that were highlighted this year at the ADA scientific sessions. And so I'm sure all of you have read the ADA standards of care front to back. What is it, 370 pages now? I have not, but I'm really going to focus in on the glycemic management section largely today. And as was noted in my intro, I've had the pleasure of being involved in updating the guidelines for a number of years. And when I joined the committee, it was pretty straightforward and very glucose-centric. Everybody with type 2 started on metformin, and from there, you picked your agent based on what you wanted to achieve in terms of weight, side effects, hypoglycemia risk, et cetera. Every single year, it gets a little more nuanced, a little more complicated. And now we're here in 2025 with this particular algorithm. But certainly, I would note that our incretin-based therapies, our GLP-1 receptor agonists, as well as tirzepatide, have really a very large footprint within this algorithm. And I think as we look at our two concurrent goals of therapies that I'll concurrent goals of treatment that I'll come back to in a moment, really often we can achieve that with GLP-1 receptor agonists and some of these incretin therapies, as long as people have access and can afford and get these medications on their regimen. But in terms of areas where GLP-1s are recommended, and I'll spend a little bit of time covering some of the recommendations and guidance. Certainly achievement and maintenance of glycemic goals. We know these are very effective glucose-lowering agents. Achievement and maintenance of weight management goals, as was noted in the previous presentation. Certainly thinking about benefits in terms of atherosclerotic cardiovascular disease risk reduction, kidney disease risk reduction, now with our FLOW trial that I'll talk about in a moment. Specific about HFpEF in individuals with overweight and obesity. And then certainly the newest addition to the algorithm, if you will, which is mitigating risk of MASH and MASLD. And so coming back to the algorithm here, looking at our two concurrent goals when we're working with people with type 2 diabetes is on the right, achieving and maintaining not only glycemic goals, but also weight management goals. And then cardiovascular and kidney risk reduction in high-risk individuals with type 2 diabetes. And really, this has become much more nuanced and detailed, certainly after a publication of some of our cardiovascular outcome trials, and then subsequent heart failure and kidney outcome trials. Here, I'm really focusing in on that right portion, achievement of weight and glycemic goals, where ADA over the last several years has given us a little bit of a hierarchy, if you will, in terms of relative efficacy of these agents for lowering glucose and weight. And you can see there in the very high area, dulaglutide, at least high dose, semaglutide, tirzepatide, and insulin are listed there as our very high options in addition to combination-based therapies with our other GLP-1 receptor agonists listed as high. And certainly within the ADA standards of care, provided the individual doesn't have obvious insulin deficiency, ADA preferentially recommends we use a GLP-1 receptor agonist or tirzepatide, preferentially to insulin in people who need the greater glucose-lowering efficacy of an injectable therapy, really based on the lower risk of hypoglycemia and beneficial weight balance with that approach relative to insulin. Also within the recommendations are specific recommendations related to weight management. So recommendation 8.15, when choosing glucose-lowering medications for people with type 2 diabetes who have overweight and obesity, which is quite a few that I work with, really prioritize medications with beneficial effect on weight whenever possible. And then really the second recommendation there is noted that if they do have diabetes, overweight, and obesity, preferentially using these incretin-based therapies such as semaglutide or tirzepatide, especially when thinking about their added weight independent benefits such as cardiometabolic and other that I'll come back to here in a moment. And so this, coming back to this right portion, achievement and maintenance of weight and glycemic goals, we talked about glucose lowering efficacy, but certainly in terms of our glucose lowering agents that can have beneficial effect on weight and institute weight loss, GLP-1RAs and tirzepatide are our big guns in that regard. We also have can get a little bit of weight loss with SGLT2 inhibitors, tends to plateau, not as robust as what we see with our incretin-based therapies. And anybody using pramlintide still? Been a while since I've seen that one, but certainly can help. Amylinomimetic agent. I include it here because at the end I'm going to come back to some of our agents in the developmental pipeline that are taking advantage of these amylinomimetics in combination with some of our other agents for added weight loss. So that's that right portion of the ADA algorithm. Here is really focusing in on the left, and that's the goal for cardiovascular and kidney risk reduction in high-risk individuals. And what has really changed over the last several years, I mentioned it's really shifted from a glucose-centric management approach to one that's more comprehensive, really looking at organ protection when indicated for individuals with type 2 diabetes. And importantly, this side of the algorithm, if you will, is really independent of the need for additional glucose lowering or an elevated A1C. So in theory, if we had an individual with type 2 diabetes, they were at their individualized A1C goal or glycemic goal, and these became a priority for management, we would quote unquote make room for these evidence-based therapies within the regimen to make sure they're getting cardiovascular and or kidney benefit with these agents. I had an individual I was consulting on just last week where that was the case. They had a recent MI. Blood glucose was fine. A1C was actually a little bit below 7, but they wanted to make sure we added on either a GLP-1 receptor agonist or an SGLT2 inhibitor to prevent secondary cardiovascular events. So we had to adjust some of their background glucose lowering therapies. This person was actually on insulin. So we did a little bit of a cross titration, actually started that person on a GLP-1 receptor agonist or in close contact to make sure we mitigate risk for hypoglycemia with that combination. And certainly, the first organ protective recommendations that came within the algorithm for the American Diabetes Association was related to mitigation of risk for atherosclerotic cardiovascular disease, as some of those cardiovascular outcome trials that were required by the FDA, really in fallout from what we saw with the Avandia, fortuitously showed benefit for many of our agents. Currently, ADA recommends and doesn't give priority to one class over the other for atherosclerotic cardiovascular disease that is established or those with indicators of high CVD risk, either a GLP-1 receptor agonist or an SGLT2 inhibitor with proven cardiovascular disease benefit, which they operationally define as those agents with an FDA indication for cardiovascular disease risk reduction. Also here within this portion of the algorithm is heart failure. Certainly with SGLT2 inhibitors, we've had a whole host of heart failure outcome trials that have shown benefit in diabetes and people without diabetes. And we've seen recommendations for SGLT2 inhibitor use within general heart failure recommendations as well. You do not see listed here within the actual algorithm itself mention of GLP-1 receptor agonists, but as I'll share with you here in a moment, ADA actually does give a recommendation specifically for GLP-1 use in a specific subset of people with heart failure. So here are some data from select cardiovascular outcome trials with GLP-1 receptor agonists. This is not all of the trials that have been conducted, but really just to show some information here. Really looking at the primary outcome, which was depending on the trial, either 4-point MACE, major adverse cardiovascular event, or 3-point MACE. Those shown in red were those that were statistically significant for benefit. And in turn, those are the agents that currently carry an FDA indication for cardiovascular risk reduction: liraglutide, semaglutide, and dulaglutide. Now, this is really looking at GLP-1 receptor agonists, specifically semaglutide versus placebo. And this was a pre-specified pooled analysis that was done with the SELECT trial, which was a cardiovascular outcome trial in obesity with semaglutide, FLOW trial, which was their kidney outcome trial, and two trials, the STEP-HFpEF trial and the STEP-HFpEF-DM trial. So in pooling these particular studies looking at heart failure related outcomes, you can see the top one there is composite of cardiovascular death or worsening heart failure event. So use of semaglutide was shown to be a benefit relative to placebo, about a 31% risk reduction on the hazard ratio. And then when looking at worsening heart failure event as well, also significantly better for those individuals randomized to semaglutide in these four trials. And I will note SELECT and the STEP-HFpEF trials were using the 2.4 milligram semaglutide dose. FLOW trial used 1 milligram. So a bit of a mix in terms of doses used within these trials included within this meta-analysis. Now, it does not yet, semaglutide, have an indication in heart failure, but this is ADA's recommendations from 2025 related to heart failure. And you'll notice the second recommendation states that in individuals with type 2 diabetes, symptomatic heart failure with preserved ejection fraction, and obesity, a GLP-1RA would demonstrate a benefit, which would be SEMA. For both glycemic management and reduction of heart failure-related symptoms is recommended, and they rated that as level A evidence based on current data. I wanted to transition a little bit and talk about chronic kidney disease. This is an area I've been particularly excited over the last several years, where we went 30 years with just ACEs and ARBs, and now we have a variety of agents that we can use in our individuals with chronic kidney disease with and without type 2 diabetes to prevent progression of their kidney disease and also help prevent cardiovascular-related morbidity and mortality. Within the ADA guideline recommendations here, you can see that in 2025, ADA said that we can consider either an SGLT2 inhibitor with evidence of reducing CKD progression, so this would be CANA, DAPA, and empagliflozin, or a GLP-1RA with proven CKD benefits. Again, this is semaglutide relative to the FLOW trial, which I'll share with you here in a moment. Going back to our cardiovascular outcome trials, fortunately, the people who developed and designed these trials included very important secondary outcomes that really precipitated some of these follow-up kidney and heart failure outcome trials, respectively, with GLP-1s and SGLT2 inhibitors. I shared with you the primary outcome from these trials, but several of these GLP-1 receptor agonist cardiovascular outcome trials, including LEADER, SUSTAIN 6, and REWIND, also included important secondary outcomes for quote-unquote worsening in nephropathy. Those definitions differed a little bit from trial to trial, but in all cases showed at least a signal, a hypothesis-generating signal of benefit on kidney outcomes with use of those agents. And I want to share with you now an algorithm that is within the ADA standards of care, but it's really based on a consensus document that was put forth by the American Diabetes Association in collaboration with Kidney Disease Improving Global Outcomes, or KDIGO. At this point in time, when I was working with ADA on the guidelines, we were really looking at how to interpret the evidence, how to recommend use of these therapies for cardiovascular and kidney risk reduction. And what we were hearing out in the community, boots on the ground, is there's all these new recommendations coming out. ADA has theirs, AHA has theirs, kidney organizations have theirs, and there's nuance and differences in how they're interpreting the recommendations and providing those, which was creating confusion at the point of care. And so really there's been this movement over the last several years for these organizations to come together and really come to a common message to really promote use of these evidence-based therapies. So this is the algorithm really based on that ADA KDIGO consensus from 2022. But again, a lot has happened in the last several years that has changed a little bit of the interpretation. But really looking at the recommendations here, you can see really we have the foundation at the top: lifestyle, healthy eating, physical activity, smoking cessation, weight management, and from there really recommendations for our various therapies to mitigate kidney and cardiovascular risk, with, of course, cardiovascular morbidity and mortality being substantial in people with chronic kidney disease. To further orient you to this particular algorithm, it is color-coded. So those in red are pertinent to all individuals with type 1 and type 2 diabetes. And those in blue are where we have evidence in type 2. So those are specific type 2 diabetes recommendations, at least at this point in time. So really looking at first-line drug therapy, of course, making sure people are on optimized RAS inhibitor therapy with an ACE inhibitor ARB, moderate to high-intensity statin as indicated. And then first-line drug therapy, and again, this is specific to type 2 or type 2 diabetes in CKD. It's recommended that people be on metformin, provided their EGFR is above 30 and its dose appropriate based on their EGFR, as well as an SGLT2 inhibitor that can be initiated anywhere from an EGFR of 20 or above. And the current recommendations are to continue use, even if they drop below that EGFR, if it's on board, down to the point of requiring dialysis or kidney transplant. From there, there is additional risk-based therapies on that next level down, which includes, you'll notice there, GLP-1 receptor agonist, and it says specifically if needed to achieve individualized glycemic goals. An additional benefit here, of course, would be additional cardiovascular risk reduction. If you buy into some of the early data showing that SGLT2 plus GLP-1s has additional incremental cardiovascular benefit. Also, at that additional risk-based therapy specifically for people with type 2 diabetes includes nonsteroidal MRA finerenone, provided if they have a persistent urinary albumin and creatinine ratio above 30 after use of these other evidence-based therapies. Now, of course, when we use SGLT2 inhibitors in people with low EGFR, we don't get as much bang for our buck in terms of glucose lowering and A1C reduction. They need those kidneys to be filtering to spill that glucose through the urine to see benefit on A1C and glycemia, which is where this GLP-1 receptor agonist recommendation came in at the level of additional risk-based therapy. I will note, however, this was designed and made really pre-flow trial. And so now really rethinking where these therapies maybe land across this algorithm. Additional benefits of GLP-1 receptor agonists in this population, really no need for dose adjustment required. Of course, I think very important that we start with a low dose, titrate very slowly. We don't want people to become nauseated, sick, and vomit and dehydrate. That's where we can potentially put people at risk for AKI and other complications. So being cautious there. I also like to be careful with bringing up AKI with GLP-1 RAs now that we know they are, at least semaglutide is kidney protective. based on the flow trial. But again, just making sure people tolerate these. We go slowly and educate them on appropriate management if they do become ill. Tirzepatide here added in, also no dose adjustments required. And early subgroup analyses are suggesting that tirzepatide, our dual GIP/GLP-1 receptor agonist, may also have kidney protective as well as cardiovascular benefits. So here's the flow trial. This was the first and only, as of now, dedicated kidney outcome trial with a GLP-1 receptor agonist. I alluded to earlier, this was with a 1 milligram dose of semaglutide in people with type 2 diabetes and established chronic kidney disease. This was an event-driven trial. Mean follow-up was right around 3 years. In this particular trial, on the left, you can see first major kidney disease event, and these are hard outcomes. This is looking at progression to end-stage kidney disease requiring dialysis, kidney transplant, or reaching an eGFR less than 15, or at least 50% or greater a drop in eGFR from baseline, or cardiovascular kidney-related mortality. You can see there the hazard ratio 0.76, so a 24% risk reduction for that first major kidney disease event. And when they pulled out the cardiovascular component for the first kidney-specific component, you can see that hazard ratio on the right, 21% risk reduction. They also showed through the statistical plan with this particular trial, less cardiovascular events and less overall mortality with semaglutide in this population relative to placebo. And so what I wanted to point out here, you may see it there with GLP-1 receptor agonist, that double dagger symbol. So when ADA was getting ready to publish their 2025 standards of care, flow trial was published pretty late in the year. And this was how ADA handled it at that point in time. That really links down to a footnote that says semaglutide can be used as another first-line agent for people with CKD. So at least based on that information in the footnote, we can consider it higher up at that first-line drug therapy level. Although, certainly we have more trials with SGLT2 inhibitors, more experience. But I would submit there may be individuals based on the big picture, what you need to achieve comprehensively with therapy, where you may consider a GLP-1 receptor agonist, especially if people have a long way to go with their A1C and glucose lowering, and we may expect a little bit of a blunted glycemic response with SGLT2 inhibitors. So stay tuned. It'll be interesting to see what ADA does with this, if anything, when they update the guidelines here in a couple months. Here are the specific recommendations from 2025. So you can see here, really putting that algorithm into verbiage here at the top, is we can consider either an SGLT2 inhibitor or a GLP-1 receptor agonist. And importantly, at the bottom, in adults with type 2 diabetes and advanced CKD, so if they have an eGFR less than 30, a GLP-1 is preferred for glycemic management due to lower risk of hypoglycemia and for additional cardiovascular event reduction. And talking about these cardiovascular and kidney benefits of these various agents, really focusing up to this point to GLP-1 receptor agonists. Certainly their metabolic benefits play into this, but growing evidence and support that they have multifactorial mechanisms at play here that lead to their benefits. And some of you, have any of you seen some of the recent commentaries about really getting people on multiple agents in chronic kidney disease really quickly, kind of this rapid onboarding of multimodal therapy? I'm not quite sure where I stand on that just yet. I get a little bit nervous when we're adding too many things on really fast in people with kidney disease and low GFR. But there certainly is a push for that and to develop treatment approaches to do that in rapid succession. All of these agents that show benefit on kidney disease are really as add-on to optimized ACE inhibitor or ARB therapy. So these are all addressing residual risk. And so you can see here really a variety of different mechanisms at play with SGLT2 inhibitors, really addressing those hemodynamic abnormalities, that glomerular hyperfiltration in the kidneys. Certainly their metabolic impact, as well as an anti-inflammatory and anti-fibrotic effects. You can see RAS inhibitors and finerenone similarly to the right, and GLP-1 receptor agonists, while having a very robust metabolic benefit. Growing evidence also showing they might have anti-fibrotic and anti-inflammatory effects in the kidney and heart as well, to conveying some of this benefit. Moving on to the last one here in terms of my list of areas within the ADA standards of care is mitigating risk of MASLD or MASH. So this was added on in 2025 at the bottom of the algorithm. Once we've addressed cardiovascular and kidney comorbidities, really thinking about the potential effects of our treatments on fatty liver. This was the ESSENCE trial that was published this year with semaglutide in MASH. This was actually a interim report for 800 individuals in this particular trial. These people had biopsy-confirmed MASH with F2, F3 level fibrosis, and they followed them out over time. You can see on the left, resolution of steatohepatitis with no worsening of liver fibrosis was one of the outcomes, significantly improved with sema versus placebo, and similarly to the right, a reduction in liver fibrosis with no worsening of steatohepatitis. The product was actually granted a expedited indication for MASH. Based on this trial, but if you look in the prescribing information, there's some language in there that says continued indication for this is potentially contingent on additional studies, but that is within the label as an indication for semaglutide currently based on this ESSENCE data. So ADA in 2025 really expanded their discussion about MASLD and MASH within the ADA standards of care. This is I think a nice figure within the guidelines, really talking about people with type 2 diabetes who have MASLD, really looking at what we can consider in terms of our obesity pharmacotherapy. So looking primarily at GLP-1 receptor agonists and tirzepatide in this regard, diabetes pharmacotherapy for targeting individualized glucose goals, again, heavily recommending GLP-1s and tirzepatide in these individuals. And then on the right, MASH pharmacotherapy if people have MASLD with F2, F3, quote unquote, at risk MASH. Resmetirom was the only one FDA approved at that point in time. I haven't seen anybody on this particular agent. From conversations I've had, really, I think hepatologists are the individuals utilizing this currently for the most part. But I think really there is a question what the ADA will do now that we have this ESSENCE data and the indication. So potentially, and I'm guessing here, maybe semaglutide will be added here specifically for mitigating risk in these individuals. And then the last one I wanted to add on is, of course, the indication where tirzepatide is now indicated for people with obstructive sleep apnea. And that was based on the SURMOUNT-OSA trial, where they studied tirzepatide and obesity in individuals with OSA. There were actually two, you'll notice if you can read it, trial 1 on the left, trial 2 on the right. So trial 1 were individuals who were not using positive airway pressure at baseline. Trial 2 is looking at individuals who were using positive airway pressure and plan to continue over the course of the trial. In both populations, really benefits in terms of apnea-hypopnea index with treatment of tirzepatide, which led to that indication within its label. And so really an expanding list of indications. I always hesitate a little bit to create slides like this. I've done it before, and by the time between submitting my slides and going to give my talk, there was a new indication. And so it was already out of date by the time I showed up to give my talk. But certainly you can see a lot of diabetes, obesity, and obesity-related comorbidities where these agents are consistently showing benefit. This is a very nice review article. It was published last year in Diabetes Care from Dr. Dan Drucker, really summarizing GLP-1 receptor agonists and associated incretin-based therapies what are their benefits? Where's the investigation going? And also talking about safety considerations and tolerability that I'll come back to here in a moment. This, of course, was before FADCES, where metabolic liver disease is there on the investigational side. But you can see for established benefit, diabetic kidney disease, MI, HFpEF, with some of the data I just shared with you, as well as stroke. So AHA and other organizations recommend GLP-1 receptor agonists for both primary stroke prevention in individuals with significant cardiovascular risk, as well as for secondary prevention. You see there for obesity, cardiorenal disorders, and type 2 diabetes, of course. On the left, which I think is an area that's pretty interesting, is it's in Alzheimer's disease, some of the work being done there, as well as Parkinson's disease and peripheral artery disease. And this certainly isn't all-inclusive. Some interesting data coming out with these agents in substance use disorders as well. So stay tuned. I feel like I'm sounding like we should put GLP-1s in the drinking water. I'm not at that point, but certainly the data is showing a lot of benefits in a lot of interesting areas. And so with that, I think really to balance, we always have to think about safety and tolerability and keeping people safe and really empowering them with information about when to re-engage their healthcare team if they do have any symptoms. This was another figure from Dr. Drucker's paper in Diabetes Care. You can see those, the coloring's a little bit difficult to appreciate on the slide, but those in gray with red writing are established. So certainly we all know the nausea, diarrhea, constipation, and vomiting. We certainly need to educate people about that, how to risk mitigate, eat small meals, stop eating when full, all of these things that are very important that we talk to people about. Reduce bowel motility, question about ileus, retain gastric contents and risk for aspiration. Certainly something we hear about when these individuals are getting ready to go in for a surgical procedure. I think still up for debate as to really how that should be handled. I think as the American or the Anesthesiology Society of America had kind of that first recommendation that came out that if people are on once weekly, stop for a week. If they're on once daily, stop for a day. We know these agents have very long half-lives. So what practically does that achieve? I think it's a little bit up in the air. I've certainly some facilities are also doing gastric ultrasounds before certain procedures to minimize risk of aspiration and related complications, but certainly an area of a lot of debate and discussion. Gallbladder disease, which I'll come back to, acute kidney injury. Certainly in the news, a lot about sarcopenia and lean muscle loss. I think to the comment earlier, making sure when people are starting these agents, we're making appropriate referrals, tapping into our dietitian colleagues, diabetes educators, making sure people are making appropriate nutritional adjustments to make sure they're getting adequate protein, make sure they're getting fat-soluble vitamins. There have been several observational reports that have come out linking at least the use of GLP-1 receptor agonists and other agents to risk for vitamin D deficiency and other things. So I think really talking to them about healthy diet and supplementation when necessary is important. And then in the brown, kind of the bottom right corner, if you will, those that are out there, but really questionable as to if it's a true link or not, which includes retinopathy. The FOCUS study with semaglutide. We should learn from that. That's that prospective study looking at eye complications with semaglutide. I think it's scheduled to end maybe late next year, early the following year. And then really those questions related to thyroid cancer and pancreatitis. Couple minutes left. 8 minutes. Okay. And so again, I think to that point, this was a nice article that came out, consensus looking at nutritional priorities to support GLP-1 therapy in obesity. Really looking at preservation of muscle and bone mass. Again, making sure people are getting adequate protein, engaging in resistance exercise as appropriate, as well as getting in and seeing their dietitian on scheduled basis. This was, I thought, a nice article, very short. It was just a quick 2-pager. It was published in JAMA Internal Medicine just a few months ago, really emphasizing dietitian referrals and diabetes educator referrals when people start incretin-based therapies. This was a little mnemonic they published called the meal approach, and talking to people about muscle maintenance, energy balance, encouraging consumption of smaller nutrient-dense meals rather than strict calorie or restriction. So having them kind of split that out over time, making sure they're eating nutritious, nutrient-dense foods, avoiding adverse effects. You can see for constipation, dietary intake or dietary fiber intake, hydration, use of OTC laxatives as necessary. Really talking to people about ways to avoid or mitigate nausea and gastroesophageal reflux, and then really making sure people are staying hydrated on these therapies. And then these are some statements from the 2025 ADA Standards of Care related to ileus, pancreatitis, biliary disease, retinopathy, and GI side effects with these. So for ileus, while risk level is not well established, provide guidance on discontinuation prior to surgical procedures. And really the recommendation is to be in contact with primary care or endocrinology and who's ever at that surgical site to make sure there's a proactive plan so people don't show up and there's a surprise that they're on an incretin-based therapy and aren't able to go through with their procedure. Really more of a communication level recommendation there. Pancreatitis, of course, if somebody develops that while on a GLP-1, discontinue and look at other alternatives. And then I think the retinopathy question, which comes up when I'm talking to people, is really an opportunity just to double down on making sure they're getting their eyes checked and educating them appropriately. For the last few minutes, I'm probably down to 6 now. I want to talk about some of the investigational agents in the pipeline. Again, I've picked 4 or 5 here. There are lots and lots of them in the developmental pipeline. But as in the previous talk, you heard from an expert all these various gut hormones and how they can affect appetite, weight balance, etc. And so really, we have many therapies that are looking at targeting GLP-1, GIP. Certainly, we have tirzepatide that targets both of those dual agonists. Also, our amylinomimetics. Nobody raised their hand for pramlintide, but we do have some agents in the pipeline that are really take advantage of amylin, and then glucagon agonism as well. You can see there decrease appetite, decrease food intake with glucagon in addition. And so I guess I landed on 4 select incretin-based therapies in the pipeline. I just wanted to make the group aware of. There was a lot of excitement at ADA scientific sessions in June about these particular agents, particularly 3 of these. I wanted to just cover a little bit of the clinical data. Orforglipron, this is an oral once-daily non-peptide GLP-1 receptor agonist. So people are going to be able to take this once daily. Non-peptide is, I think, important and unique here. There's potentially cost ramifications. It's going to be less expensive to produce potentially than peptide-based therapies. What that turns into in terms of cost to the patient, I guess we'll see if this makes it to the market, but potentially some financial and coverage considerations. And I think for individuals in remote areas, we don't have to worry about that cold chain transportation and storage with this necessarily either. Cagrilintide and semaglutide, or CagriSema. This is a GLP-1 receptor agonist that you're all familiar with. Semaglutide in combination with a long-acting amylin analog, cagrilintide. There's also a variety of triple agonists. I'm going to share some data with one of these. It's a triple GLP-1, GIP, and glucagon agonist, retatrutide. Quick aside, I got an email about a week ago from an online compounder that was selling retatrutide. So I didn't purchase any. And then we have Maritide, which is another pretty unique and interesting medication. The picture there shows it. So it's actually an GIP receptor antibody. So as opposed to tirzepatide, where we're activating GIP, this is an antagonist with a GLP-1 analog peptide. So this is given by injection, but it's actually injected once monthly. So less frequent administration on this one. So some of the data, I'll start with orforglipron. This is a 72-week obesity data, looking at change in body weight from baseline to week 72. 3 different doses here relative to placebo. You can see percent change in body weight ranged from 7.5 to 11.2% absolute weight reduction with that particular agent in this particular study. This is looking at those weight reduction thresholds from the same trial, 72-week obesity data with the various doses in blue relative to placebo. And you can see there at the higher dose, 36% of participants randomized to that 36 milligram dose achieved 15% or greater weight reduction over the course of the trial, and a smaller proportion achieving that 20% weight loss threshold. These are top-line results. This is from the company released some early results. This is the ACHIEVE-3 trial where they actually took orforglipron and tested it head-to-head with oral semaglutide, 7 milligrams or 14 milligrams. You can see this was a 52-week open-label study, 1,600 individuals with type 2 diabetes who were over their A1C goal on metformin. Baseline A1C was 8.3%. Mean baseline weight was 97 kilograms. So you can see the primary outcome I've included there in bold and italics was change in A1C at 52 weeks. So better with orforglipron than the oral sema doses tested here. And you can see some weight loss, as I shared with you from the other study, and also percent of individuals achieving an A1C less than 5.7% at 52 weeks was over 25% with orforglipron in this particular trial. So weight loss with very effective A1C lowering and achievement of A1C targets potentially for individuals. I did want to point out, though, for balance here, we're comparing orforglipron to 7 milligram oral sema and 14 milligram oral sema. Oral semaglutide is being tested up to a 50 milligram oral dose. So if you look at this particular data, this was published in 2023 in Lancet, as would be imagined, additional change in body weight with that elevated dose, and that's being actively pursued for an obesity indication. Redefine 2, this is with CagriSema. This is in people with type 2 diabetes and overweight or obesity. On the left, I'm showing a change in body weight from baseline. You can see overall mean body weight at baseline was about 102 kilograms. So with the cagrilintide semaglutide combo, 15.7% change in body weight over 68 weeks. And then on the right, change in glycated hemoglobin minus 1.8% relative to baseline. And certainly ongoing phase 3 trials with this particular GLP-1 amylin agonist therapy. And then this is our triple agonist, retatrutide. This is a type 2 diabetes phase 2 trial with a variety of different doses. But again, you can see A1C reduction with this particular approach, as well as change in body weight, which was dose related. One of the things they looked at this particular study is if they did a dose escalation type approach to get to a target dose, or just take them straight there. And as we might expect, those individuals who started a lower dose and had a slower titration tolerated the agent much better from a GI standpoint. And then once monthly Maritide for obesity. So this is that GLP-1 agonist, GIP antagonist. And, animal studies show that when used in combination with GLP-1 receptor agonism, either GIP agonism or antagonism results in additive weight loss with that combination. So this is looking at the GIP antagonism. But you can see their mean change in a percent in body weight on the left. I know it's a little bit small. Yeah, that's in the obesity cohort. So this is people with obesity without diabetes. 20%. weight loss, and on the right, people with diabetes, where they tend to hang on to weight a little bit more, less of a weight loss over time, but promising results. And again, once monthly. I'm out of time. I'll leave the key takeaways on the screen and entertain any questions if we have time.
Right, so I do want to give you guys the boring, you guys can finish it for a long time, but I'm hoping Josh will stick around and do both of them.
Absolutely.
That's okay for you guys to just look at and talk to me. However, that will get to what you can to lunch, there's product feed in this room or the other room, so go with your schedule. If you want to be, it's not cheap, or in the other room. And then repeat the world with and other people so for 12 to 14. Thank you very much.
Uh-oh. Yeah. So they weren't pushing the doses to 10 or 15 That's